back. Hi, good evening, good evening. Hi, Raj, good evening. Hope everybody is doing fine. All right, so I hope everybody is able to see me, able to hear me. So let's start with today's topic. In fact, today is our 49th episode of BLS. We are one short of a half century. We are going to do it tomorrow. Join us tomorrow for sure. We'll celebrate our 50th episode of BLS. Hi, Aditya. Good evening. So today we are going to talk about a very important topic in our general surgery, that is esophagus, and the topic goes by the name of GERD. GERD stands for Gastro Esophageal. It's a gastroesophageal reflux disease. So the today's topic that we are going to emphasize on is going to be a very common thing that you will encounter in your OPDs, right? These are the patients that you will see on a daily basis. In fact, when you go down to your general surgery OPD, one in every 5 patients will come down to an epigastric pain, probably because of your GRD, that is a gastroesophageal reflux disease. Now, what is the gastroesophageal reflux disease? There is a definition which is given by the Montreal definition, or called as the Montreal classical definition of GRD. According to the Montreal definition of GRD, it is defined as the pathological. It is defined as pathological reflux of gastric content. It is a pathological reflux of the gastric content into the esophagus, producing symptoms. Into the esophagus producing symptoms is what we call it as GRD. The classical definition of GRD according to the Montreal. Now this is the most accepted definition that is there for GRD. It is called as pathological reflux of the gastric content into the stomach, from of the gastric content into the esophagus, is what we call it as GRD. Now, if you want to get a grip of what we are trying to talk about it, now take this as the representation of the esophagus and this is the representation of the stomach, right? So this is the esophagus, this continues as stomach. We know there is the diaphragm which is present here. We have spoken about diaphragm in a lot more detail. We'll add a bit more detail as well. Now, as I said, there's a pathological reflux of the gastric content. So whatever the gastric content is produced in the stomach, it is now refluxing from the stomach into the esophagus. Now, as it reflux from the stomach into the esophagus, this reflux of gastric content, when it causes symptoms, in the esophagus, this is what we call it as GRD, right? So GRD is nothing but a pathology. See, there are physiological refluxes. That means for you and me also, once in a day, twice in a day, maximum 3 times in a day, there's some amount of reflux that is happening. But if the reflux encompasses or it goes more than 4 times a day and also produces symptoms, that is what we call it as GERD, right? Thank you, Raj. Now, when we say the whole component of GRD relies on this concept that because of some XYZ reason that we're going to discuss now, you see the gastric content is refluxing into the esophagus. Once it refluxes into the esophagus, it produces symptoms. So, right, it produces symptoms. So, that is what we call it as gastroesophageal reflux disease. Before we move on any further, let's establish a base cause for GRD. Why is this happening? Why is the acid which is there, or why is the gastric content which is supposed to be in the stomach is not staying in the stomach? Why is it refluxing into the esophagus? We all have read before also, we have a sphincter that is called as a lower esophageal sphincter, which should be at this area. It should prevent the reflux, but it is not able to do so. So if I say what is the most important mechanism, so if I just list down the most important mechanism for GRD, it is either decrease or loss of tone in lower esophageal sphincter. Now, by hook or by crook, we don't know what is the reason. We'll discuss them in a bit. But if anything that leads to decrease in the tone or loss of tone, obviously this part will become lax. Now, if it becomes lax, every time the stomach contracts, it generates pressure. Now that pressure will now spill the content in all directions. Earlier there was a sphincter, it was not allowing the content to move into the esophagus. Now the sphincter has given away. Now as sphincter has given away, the content will start to go back into the esophagus. So the whole concept is very simple. If I say what is the mechanism or the single most important mechanism that results in this reflux to happen, and that most important mechanism is nothing but decrease in or loss in tone of the lower esophageal sphincter. As simple as that. Now my question to you is, what causes this decrease? So we are more worried about what is the reason that the tone at this area, that is at the lower esophageal sphincter. So we're talking about the lower esophageal sphincter, right? So if you want to know what are the components of the lower esophageal sphincter, we have discussed that in our previous lecture on the esophagus. That is the esophageal anatomy. Just go look at the components. You will understand that lower esophageal sphincter is a physiological sphincter. It is not an anatomical sphincter. Now coming back to here. Now what is the whole concept behind it? Why is the lower esophageal sphincter losing its tone or decreasing its tone, right? One, I can say it is tired in life, as most of us are, so we often lose our cool, but that is not the case here, right? So let's understand what are the risk factors to decrease. So we're talking about the risk factors that results in decrease in tone of lower esophageal sphincter, right? So we're trying to understand what are the risk factors to decrease the tone of the lower esophageal sphincter. ऐसा भी क्या है कि भाई लोअर esophageal sphincter का टोन जा रहा है, ठीक है, क्यों डिक्रीज हो रहा है? नाउ सबसे इंपॉर्टेंट, ठीक है, we'll try to visualize it. The most important risk factor is going to be smoking, right? तो सबसे important risk factor for decrease in tone of LES is going to be smoking. तो अब मान लो कि एक चाय की टपरी है, ठीक है. Yes, you can imagine whatever tapri you want. Imagine that there is this nice chai ki tapri which is present, which is usually outside our medical college. तो मान लो ये हमारे चाय वाले भैया की दुकान है और यहाँ पे चाय वाले भैया बैठ के चाय बेच रहे हैं, ठीक है. तो उनका तो काम है ना चाय बेचना, लेकिन आप सिर्फ चाय पीने नहीं जा रहे हो ना, वहाँ पे बाकी और भी चीज़ें बहुत मिलती हैं. तो आपने डिसाइड किया एक काम करते हैं यार, अभी थक गए हैं पढ़ते पढ़ते, भैया के पास जाते हैं और चाय पीते हैं. तो आपने भैया को बोला भैया भैया एक चाय देना, तो भैया ने दे दी एक चाय. अब आपके एक हाथ में चाय है, ठीक है. सो दिस इज वेयर यू हैव अ हॉट कप ऑफ टी, ठीक है. तो पता भी तो चलना चाहिए कि गर्म है, तो गर्म चाय में फ्यूम्स डालेंगे, ठीक है. तो ये आपकी गर्म चाय होगी. अब देखो सिर्फ चाय कौन पीता है, एक हाथ में चाय है तो आपको तो पता ही है, अब मेडिकल कॉलेज में इतने लोग हो, अब इतना स्ट्रेस होता है, तो व्हाट इज द बेस्ट फॉर्म ऑफ रिलीविंग द स्ट्रेस? आई एम नॉट एंडोर्सिंग इट, लेकिन आप लोग करते हो ना, क्या करते हो भाई? आप क्या करते हो कि भैया एक हाथ में चाय है, अब जो सड़ी सी शक्ल आपकी है उसको हैप्पी करने के लिए दिस गाय टेक्स आउट एंड रीचेस टू इट्स बेस्ट फ्रेंड एंड देन स्टिक्स इट्स बेस्ट फ्रेंड आउट, और ये हमारा फैक्टर, ठीक है. तो सबसे इंपॉर्टेंट रिस्क फैक्टर जो है वो आपकी स्मोकिंग है. तो स्मोकिंग रिजल्ट्स इन डिक्रीज इन द टोन ऑफ एलईएस. स्मोकिंग के साथ दूसरा क्या है? दूसरा उसके हाथ में क्या है? एक हाथ में सिगरेट है तो दूसरे हाथ में चाय कॉफी है, तो कॉफी इज अ मेजर कल्प्रेट. सो द सेकंड थिंग दैट रिजल्ट्स, the second thing that results in decrease in the tone of LES, it is going to be caffeine. अब देखो, आप गए कॉलेज में, ठीक है, कॉलेज में ब्रेक मिला, आप गए चाय की टपरी पे, आपने एक चाय पी, एक सिगरेट फूक ली, ठीक है. नाउ वंस यू आर डन यू हैव टू गो बैक टू द क्लास. नो, आपको नहीं पता चला, यू डोंट वांट योर कलीग्स टू नो दैट यू हैव नो हैड whatever you had, right? So in order to prevent that, आप कैसे उसको छुपाओगे? आप बोलते काम करते हैं यार कुछ चॉकलेट खा लेते हैं ताकि किसी को सूंघने में ना मिले. तो द चॉकलेट विच इज शुगर्स पर से ऑल्सो डिक्रीज द टोन ऑफ एलियस, ठीक है. अब पूरा दिन लेक्चर में थके हारा इंसान घर जाएगा तो थोड़ा रिलैक्स तो करेगा ना यार. ना व्हाट इज द बेस्ट फॉर्म ऑफ रिलैक्सिंग? अब आपको ये वाला सीन भी याद रहेगा ना. आप घर जाओगे, इमेजिन करो कि ये आपका रूम है, आप गए अपने रूम के अंदर और रूम में आपके चार दोस्त, तो ये आपका रूम है. बिफोर यू एंटर इनटू द रूम, आपका ये दोस्त नंबर एक ऑलरेडी बैठा हुआ है, ठीक है. आपका दोस्त नंबर दो भी बैठा हुआ है, फिर दोस्त नंबर तीन भी बैठा हुआ है, तो आप हो आपके दोस्त नंबर चार, ठीक है. अब जब चार दोस्त बैठ ही गए हो तो ऑब्वियसली बतियाओगे थोड़ी ना, राइट. तो आपने डिसाइड किया कुछ करते हैं, एंड द बेस्ट फॉर्म टू रिलैक्स इज आर बिग ब्रदर, ठीक है. तो आई होप एवरीबडी समझदार को इशारा काफ़ी है, एंड दिस इज व्हाट यू डू. once you go back to your college. ठीक है, so घर जाने के बाद this is the best form of relax, right? So this is the way you relax, right? So we call it as the way to relax. ठीक है, तो chill कर रहे हो. अब इसकी वजह से टोन और खराब होगा. ठीक है, फिर बोलोगे सर मुझे ये प्रॉब्लम क्यों होती है, तो फोर्थ इंपॉर्टेंट कंपोनेंट इज गोइंग टू बी अल्कोहल. ठीक है, तो कॉलेज गए तो ब्रेक लिया, ब्रेक में लगा कि चाय कॉफी पी लेते हैं, उसके बाद सुट्टा मार लेते हैं, वो एक रिस्क फैक्टर हो गया. अब उसको छुपाने के लिए आपने सोचा चॉकलेट खा लेते हैं, वो अनदर रिस्क फैक्टर हो गया. घर गए और थक गए लगा है, तो थकान को दूर करने के लिए आपने डिसाइड किया कि सर थोड़ी दारू पी लेते हैं, एंड दैट इज द अनदर रिस्क फैक्टर, दैट इज फोर्थ रिस्क फैक्टर. अब नेक्स्ट डे उठोगे तो ऑब्वियसली सर तो घूमेगा. अब सर घूमेगा तो घूमने वाले सर को बचाने के लिए क्या करोगे, कुछ दवाइयां लोगे. सो देयर आर सर्टेन ड्रग्स व्हिच आर गोइंग टू इंक्रीज और सॉरी रादर डिक्रीज द टोन ऑफ एलियस. तो ऐसे कौन से ड्रग्स हैं दैट डिक्रीज द टोन ऑफ एलियस, कैन बी रिमेंबर्ड बाय अ स्मॉल निमोनिक कॉल्ड एज ABCD. और ABCD का मतलब क्या है? A स्टैंड्स फॉर एंटीकोलिनर्जिक, it is your anticholinergic. B stands for barbiturates. B stands for barbiturates. C stands for calcium channel blocker, and D stands for diazepam. And D stands for diazepam. So A is anticholinergic, B is your barbiturate, C is your calcium channel blocker, D is your diazepam. These are the drugs that decrease the tone of LES. So lower esophageal sphincter का जो tone है, it is lost because of smoking, caffeine, chocolates, alcohol, and the drugs that we have just mentioned decrease the tone of LES. Now, because we have spoken about drugs that decrease the tone of LES, I also want you to know that drugs that increase the tone of LES, right? Drugs that increase the tone of lower esophageal sphincter. Now, why I'm telling you this? Common sense. No, already you know that the tone of the LES is decreased. अगर इसको बढ़ाना है तो कौन से drugs दोगे? Which drugs would you prefer giving it to increase the tone of LES? Number one, it is going to be antacids. Number two, it is going to be domperidone. Number three, it is going to be metachlorpromides. So we have antacids, domperidone, and metachlorpromides. These are the drugs that increase the tone of LES. So we know the drugs that decrease the tone of LES. We also know the drugs that increase the tone of LES. So जब भी LES का tone decrease करेगा, उसको बढ़ाने के लिए वाला drug देंगे, तो we know what drugs to give, and that's how you're going to treat if the tone of LES is going to drop down. But if I say what are the pure risk factors for GRD, ये सब तो ठीक है, ठीक है. If I simply ask you what are the risk factors for gastroesophageal reflux disease, right? Now, the most important or a single most important risk factor for GERD, it is going to be obesity. Now, if I have to give you, is the volume, is anybody facing an issue with the volume? Is it audible, guys? Just a quick recap and feedback on the chat box. Are you able to hear it clearly? Clear है? ठीक है सर? Okay sir, बढ़िया. Right, so obesity is one of the major risk factors. Next is going to be pregnancy. So when you talk about obesity, you know, in the obesity, because of the central fat deposits, the crural segments, or I can say the crust of the diaphragm, becomes weaker. So the gastroesophageal junction, which is tightly held by the diaphragm, which is also a component of your lower esophageal sphincter, becomes weak. And because of that, obviously there's some amount of sliding hiatal hernia, which disrupts your lower esophageal sphincter mechanism, hence promoting the GERD. So obesity is a very important risk factor. Pregnancy में ना, the problem is progesterone driven status. Now progesterone is a smooth muscle relaxant, and because of that smooth muscle relaxation, the lower esophageal sphincter is also smooth muscle. No, the tone gives away. Now as the tone gives away, the reflux is going to become increase or more progressive. So hence again, it's an important risk factor. Now apart from that, smoking not only decreases the tone but also enhances or causes GRD with the same phenomena. So we'll also take it as a risk factor. A connective tissue disorder like scleroderma, right? All these are considered to be as pure risk factors for GRD, but if you look at the whole shell of GRD, you see these patients with the components which are discussed to decrease the tone of LES, right? So an obese guy, imagine what is the worst combination. एक मोटा बाय, एक मोटा लड़का, और I can say a मोटा person जो स्मोक भी करता है, ड्रिंक भी करता है, चॉकलेट भी खाता है, ठीक है, उसके लिए बहुत दिक्कत हो जाएगी, बिकॉज दैट पेशेंट इज नाउ गोइंग टू हैव GRD फिश शॉप, ठीक है. नाउ how would a patient of GRD will present to you? So we'll talk about how we will see them in our clinic. So we'll talk about the clinical features of the gastroesophageal reflux disease. So rather than trying to mug the clinical features, we'll try to understand कि भाई हर एक फीचर होता क्यों है, ठीक है, क्यों पेशेंट हमारे पास आता है, ऐसी भी क्या मजबूरी है, और जब आ ही गया है तो आप क्या करोगे, ऑल दैट यू हैव टू फिगर दैट आउट, ठीक है. तो इन दैट कॉन्टेक्स्ट लेट्स अंडरस्टैंड द होल फिनोमेना ऑफ GRD. अगर आप देखोगे, सो दिस हैपेंस टू बी the esophagus, this happens to be the stomach, right? We have established a fact that we have the lower esophageal sphincter which is present at this component. This is where you have the diaphragm. We also know that the entire esophagus is going to be lined by the squamous epithelial cells, but the last 2 centimeters which is present here is going to be lined by your columnar epithelial cells, and that is your squamo-columnar junction which is present, right? Now here's an important aspect. In the gastric type of mucosa, or I can say where you have this transition into the squamous to adeno, you will notice that they will be able to produce mucus because they have mucus producing cells. Now as they have mucus producing cells, they will produce mucus, so there will be a protective layer which will be present on the mucosal surface of the stomach as well as the rest of the GIT, and that is because of mucus producing cells that produce mucus. Now what is so special about this mucus producing cells is as they produce mucus, number one, they act as a mechanical barrier. That is the first thing that they do. Secondly, mucus is also rich in bicarbonate, so which can neutralize the acid which is going to be produced from that of the stomach. So as we all know, the stomach is going to produce the hydrochloric acid. Now this hydrochloric acid is the reason why you have a pH of the stomach which is between 1.5 to 2. Now such low pH or such acidic pH in the stomach is only because of this hydrochloric acid which is produced by your parietal cells, right? Now imagine such an acidic or a concentrated component that is secreting into the stomach does not cause any problem in the stomach because this mucus which is present here is going to act as a barrier. Another interesting thing is because it consists of bicarbonate, the acid when it combines with the base, it neutralizes it. So hence the underlying surface is unfazed. There is no problem at all. So stomach bolta hai, bring it on. Acid, no acid, I don't care, right? Because he's so well prepared कि जितना भी एसिड फेंकोगे भैया मेरे पास तो म्यूकस है, वो एक तो मैकेनिकल बैरियर भी है, दूसरा बाइकार्बोनेट है, मैं उसका बैंड हो जा दूंगा, तो एसिड इसका कुछ नहीं बिगाड़ पाता. Now the problem is once the reflux will start to happen, you will see this acid will start to reflux. Initially it will go and fall on the last 2 centimeters of the esophagus, which is also lined by your columnar epithelial cells. So it says I am also not worried about, right? So because the last 2 centimeters also have mucus, it is chill. But one fine day, it was a bad day when this acid is now going to reflux onto the squamous epithelial cells. Like in squamous के पास कोई protective nature है ही नहीं. They don't have mucus, they don't have bicarbonate. तो acid जब गिरेगा squamous cell पे तो जलेगा ना भाई. अब जब जलेगा तो दर्द होगा, और वही हमारी patient की पहली पहचान है और the first complaint. The first complaint that the patient is going to now run down to you and rush down to you is going to be presence of sudden severe onset. There will be sudden severe onset of retrosternal. It is your retrosternal heartburn. It is your sudden severe onset of retrosternal heartburn. सच में जलता है. पेशेंट बोल रहा है कि जलन महसूस हो रही है. भाई वो महसूस नहीं, सच में जल गया है. And that is why the patient is rushing to you and says sudden severe onset of retrosternal pain. भैया like doc बहुत जल रहा है भाई, and it is very painful. It is very irritating also. Trust me on that. ठीक है. अच्छा. Now this pain, I mean this is because when the acid is refluxing onto the esophagus and it is causing the damage in the esophagus. ठीक है. जैसे ये esophagus में गया, इसने esophagus को जला दिया. ठीक है. तो भी इसे जला डाला. ठीक है. यहाँ पे esophagus का जो squamous epithelial है, This is now burnt out. Now this burnt out esophagus is now going to cause pain. It is going to cause ouch, dard ho raha hai. ठीक है. Now problem ये है, you need to understand that the whole GIT is divided into foregut, midgut, hindgut. अब foregut derivative का जब भी पेन होता है, whenever you have pain which is going to be because of an injury in a foregut derivative, that is going to be epigastric, midgut is going to be periumbilical, hindgut is going to be in the lower abdomen or in the pelvis. As simple as that. तो obviously esophagus belongs to a foregut status, so यहाँ पे जो pain होगा it will be epigastric, so hence these patients are also going to have epigastric pain, right? So one, you need to have a sudden severe onset, a patient will present with sudden severe onset of retrosternal pain, which is going to be heartburn or that described typically as heartburn, and also an epigastric pain as well as an epigastric pain. Okay. Now, as you know, the whole problem is occurring because there is loss or decrease in tone of LES. तो अगर acid reflux करता है तो खाना भी reflux कर सकता है, and when the food refluxes, it will be felt in the mouth. So patient will have regurgitation. Patient is going to have regurgitation of food particles. पेशेंट बोलता है कि जो खाया मुझे लगा पेट में गया लेकिन वापस मुंह में आ गया, ठीक है, उसको लग रहा मैजिक हो रहा है. भैया मैजिक मैजिक ही नहीं हो रहा, बैंड बज रहा है, ठीक है. एंड इफ यू कंटिन्यू इग्नोर इट इज ओनली गोइंग टू गेट वर्स. सो एक तो हार्ट बर्न हो गया, दिल जल गया, ऊपर से पेट में भी दर्द हो रहा है, दिल में दर्द हो रहा है, पेट में दर्द हो रहा है, ऊपर से जो खाया वो भी वापस आ रहा है, तो मतलब प्रॉब्लम तो है. नाउ व्हेन यू आस्क दिस पेशेंट, पेशेंट विल आल्सो टेल यू कि आजकल एक नया प्रॉब्लम हो रहा है. Now, as the tone is going to become more and more lax, so the reflux of the acid is only going to become progressive. कि और थोड़ा ऊपर, और थोड़ा ऊपर, और थोड़ा ऊपर, और one fine day it is so going to happen that is now going to come and fall onto the tongue. तो मुंह में जाएगा, मुंह में जाके आपके पेशेंट के जबान पे गिरेगा. Once the acid goes, and falls onto the tongue, now the patient can taste the acid. ठीक है. अब एसिड जब टेस्ट करेगा अच्छा थोड़ी ना लगेगा, तो ये लगेगा कि ऐसा कुछ मुंह में खट्टा आ गया, राइट, बिकॉज द एसिड हैज दैट टेस्ट, एंड that's not a nice taste to have. It is what we called as the sour brush. So patient is now going to present to you with sour brush कि बोलेगा मुंह में खट्टा खट्टा लग रहा है, ठीक है. सो एसिड से टंग जल गया, तो टंग में जो वो फील आता है दैट इज गोइंग टू कॉल्ड एज सावर ब्रश, ठीक है. सो पेशेंट हैड अ retrosternal heartburn, epigastric pain, regurgitation of food particles. This presents a sour brush. Now, अब मान लो कि पेशेंट अभी भी बाज नहीं आया, he is still not taking any medical attention. He decides कि मैं खुद ही सॉल्व कर लूंगा, कोई दिक्कत नहीं है. The acid reflux is only going to get more and more progressive. Now, as it gets more and more progressive, the next stop for this acid is now going to fall onto the teeth. अब वो जब teeth पे गिरेगा, on the teeth you have this white cover which is called as enamel. Enamel is acid sensitive, और जैसे ही वो enamel पे गिरेगा वो enamel का बैंड बजा देगा और enamel disrupt हो जाएगा, तो ये दांत का जो कलर है, the teeth's color is going to become very disruptive, and this is what we call it as yellowing of the teeth. यहाँ पे पेशेंट को मिलेगा कि उसके दांत भी खराब हो गए हैं. सो पेशेंट इज नाउ गोइंग टू प्रेजेंट टू यू विथ येलोइंग ऑफ टीथ. Patient is now going to have the yellowing of the teeth, right? So you can see all the points. There is heartburn is present, there is epigastric pain is there is regurgitation of food particles, there is sour brush, and there is yellowing of teeth. All these points towards only one effective diagnosis that you have, that is going to be your GERD. Now, there's a very important thing that these all what you're talking about, these are what we call as GI manifestations. Okay? So whatever we have learned until this point, whatever we have learned until this point is what we call it as the GI manifest, that is gastrointestinal manifestations for GERD. Now, GERD is a condition that is not only going to be limited to that of the GI symptoms. Okay? So when you come down to that, what are the extra-intestinal manifestations? What are the extra GI manifestations? What are the extra esophageal or extra GI manifestations? So what else these patients can present to you? Whatever we have told, all that logical components, they are going to be on the GI format. So what are the extra GI manifestations that our patients can present to us? Now, in an extra GI manifestations, now as this acid, now because this reflux is happening, it is becoming progressive. Now this reflux, as it is going up, it can also go from the esophagus into the trachea, that is from the pharyngeal component, it will go into trachea, cause the irritation. Now because of that, it is now going to cause chronic irritation of the larynx, resulting in chronic cough. So these patients can also land up with chronic cough, inflammation of larynx, which is called as the laryngitis. Inflammation of larynx causes laryngitis. It can trigger asthma, or also called as presenting as asthma like symptoms, and then it can also result in erosions on tongue. It can also result in tongue erosions. So these are basically the pulmonary manifestations of GERD: chronic cough, laryngitis, asthma, and the tongue erosions, all because the acid is refluxed and now causing the component. Those who are not able to comprehend, we have already discussed in great detail. Just for a recap, in the anterior component, you have the trachea, which is present here. On the posterior component, you have the esophagus, which is here, and then you have the laryngeal component, which is going to be present at this component, and then you have the common pathway, which is going to be here, and this is your oropharynx, which is present. Now every time the acid is going to reflux, every time the acid is going to reflux from the esophagus, as it is refluxing, it is going into the mouth, some amount of acid can reflux here, and this is going to cause irritation of the larynx, that can result in chronic cough and laryngitis. Pretty explainable and understandable. Now as it goes further deep in, it can cause asthma like symptoms, as well as tongue erosions. Now imagine if the acid becomes more and more progressive, it is now going to go into the lungs as well, and the manifestations are only going to get worse from there. If it goes into the lungs, right, what is going to happen? As it enters into the lungs, it can result in pulmonary fibrosis as well. It can result in pulmonary fibrosis, or it can start triggering the pulmonary fibrosis. The other conditions that it can cause, now because the larynx is going to get affected, as it goes up, it is now going to cause the irritation of the nose as well. And you know, the eustachian tube is going to open from the middle ear into the nose. Obviously that is going to get irritated, hence there will be middle ear component that you have. So patient will have recurrent otitis. The patient is going to have recurrent otitis media. The patient is going to have recurrent otitis media, as well as sinusitis. Right? So these are the extra GI manifestations. Again, this was something that was asked in our recent exam, that is your competitive exam, in your INICET as well. Okay? So make sure such points are important. Everybody concentrates on knowing what's happening in the esophagus, but you should also have a fair idea, that is what is happening beyond esophagus for the same disorder. Now, as you know, this is the logical explanation of chronic cough, laryngitis, asthma, tongue erosions, pulmonary fibrosis, recurrent otitis media, as well as sinusitis. Do not ignore these symptoms. They are very, very, very important. Yep. Now, once you have the patients, usually the patient comes to you with these symptoms, you can help them up, you can start the diagnostic work, you can start the management, but most of these patients continue to ignore, right? Because over the counter, you have the proton pump inhibitors, which is most widely abused drug that we have, and as you take it, obviously the symptoms subside, patient feels better, goes back home. So what happens is, if the GERD goes untreated for a prolonged period of time, it can now get into complications, right? So what are the complications that can result in GERD? So we talk about complications associated with GERD. So what are the complications? What are the complications which are associated with GERD? So try to understand that what are the various forms of complications that can occur in GERD. Again, we'll take a logical approach so that we understand better. When we talk about the complications, let's take the same presumption that we have. Let's say this happens to be the esophagus. This happens to be the stomach. and we say this is the diaphragm which is holding up across here. Now, as you know, every time the acid is going to reflux into the esophagus, it is going to cause the esophageal injury. Now, esophageal, any injury in the body will heal by inflammation. So that inflammatory response that you experience out here is what we call it as esophagitis. So these are the patients who will have features of esophagitis. So these patients will have esophagitis. Now what will happen is this recurrent esophagitis, this repeated esophagitis, repeated esophagitis will result in something called as the feline esophagus. It will result in something called as a feline esophagus. Now feline esophagus is also seen, the feline esophagus appearance is also seen in eosinophilic. It is also seen in eosinophilic esophagitis. It is also seen in eosinophilic esophagitis. Now, this is classically described as a stacked mucosal ring. This is classically described as the stacked mucosal rings. Now, what do you mean by this is, normally when you look at the esophagus, this is how a normal appearance of the esophagus would look like. In a stacked mucosal rings, you will see the esophagus appearance from a normal lumen is now going to become like this. You will see it is now going to have these bands which are going to running through the mucosal surface. Now it looks like a channeled one. So when you look from inside, when you go look at inside, this is how the esophagus is now looking. Now that smooth border of the esophagus is lost, and this is how the esophageal lumen looks from inside. And this is what we call it as a feline esophagus, or also called as stacked mucosal ring, as simple as that, right? So one complication is it can result in esophagitis. Now repeated inflammation is going to heal by fibrosis, and that fibrosis will result in narrowing. So you will notice that this areas of the esophagus is now going to get hampered. Now, as repeated areas are going to get hampered, these areas are now undergoing fibrosis, right? So the second complication that I can expect is going to be an esophageal stricture. It is going to result in esophageal stricture. Now, whenever there is an esophageal stricture, it is going to cause narrowing of the esophagus, and any narrowing of the esophagus will result in dysphagia. Remember here, dysphagia is usually only for solids, because it does not narrow to that point where the liquids can get hampered. But yes, definitely the lumen is going to get narrower or smaller, and this narrowed smaller lumen can result in difficulty in passing of solid foods. So hence patient can have dysphagia for solids, right? So there is esophagitis, there is esophageal stricture that is going to have. Now every time there is a stricture, you need to understand, if this is a stricture, the tissue is going to condense. It is going to become smaller. Now as the tissue condenses, what will happen to the length of the esophagus? The esophagus is here. If the tissue condenses, it is going to become smaller. So this is what we call it as shortening of the esophagus. So the third complication that you will see is going to be presence of shortening of esophagus, right? The third thing that you have is going to be a shortening of the esophagus. So you have esophagitis, there is an esophageal stricture, there is a shortening in the length of the esophagus. Now what is going to happen is, as the length of the esophagus is going to get shortened, I'm not worried about shortening, I am worried about what will happen to this gastro-esophageal junction. Now we'll consider this as the gastro-esophageal junction, which is present here. You can see the G junction is here. Now when it becomes smaller, as the length is shortening, what will happen to G junction? The G junction will also move up. There is shortening here, the G junction is going to move upwards, and this migration of the G junction up and above the level of diaphragm, this is what we call it as the cranial migration of the gastro-esophageal junction. In simple words, it is called as the sliding hiatal hernia. You will now notice, because of this, the G junction, which is supposed to be present inside the abdomen, is now moved above the level of diaphragm. So now the gastroesophageal junction, which is supposed to be in the abdomen, will now be formed, or it will be found in the intrathoracic space. Hence it is called a sliding hiatal hernia, worsening the symptoms of GERD. Right? So esophagitis, stricture, shortening in the length of the esophagus, sliding hiatal hernia, and the last one, which I would not want my patient to suffer, and that is going to be your Barrett's esophagus. That is going to be your Barrett's esophagus, right? Now, obviously, everybody's like, hey, what is this Barrett's esophagus? Now we need to understand what is this Barrett's esophagus, right? So let's quickly talk about what does this Barrett's esophagus basically mean. It's a complication. We're going to talk about the Barrett's esophagus. When we talk about Barrett's esophagus, now first, what is the reason behind it? The cause for the Barrett's esophagus is simple. It is long standing. It is a long standing untreated. It is a long standing untreated GERD is what is going to result in Barrett's esophagus. Let's understand this. Now, if you take this as the representation of the basement membrane, let's say this is the component here, and you see there are two forms of cells we have. Number one is your squamous epithelial cell, and number two, there are these columnar epithelial, the tall columnar epithelial. Now, what is going to happen is every time you see the acid is going to come and fall onto the squamous cell, there is no problem at all. The squamous cell says, I am all good, I am cool. But the same acid, when it goes and falls onto the squamous epithelial cells, you see the squamous epithelial cells are getting damaged, right? So you will notice that these are the squamous cells which are going to get damaged, and these are the columnar epithelial cells which remain unfazed, right? So body says that if you have a columnar epithelium, it is protective for acid because it has mucus which is acting as a mechanical barrier, also bicarbonate, neutralizing the acid. All that is working in favor. In the squamous epithelial, they're susceptible to acid. So squamous epithelial cell says, hey, listen, every single time no, तेरे पे acid गिरता है, तेरे पे कोई problem ही नहीं होता, मेरा बैंड बज जाता है. तो कॉलनर बोलता है, भाई एक काम कर, जब तुझे पता है कि एसिड से तू जल रहा है तो क्या कर, तू भी खुद भी कॉलनर बन जा. तो ये पॉसिबल है, हाँ हाँ पॉसिबल है. बोलते कैसे? नाउ द पॉसिबिलिटी इज बाय दिस. ठीक है, बॉडी बोलती है एक काम करते हैं, सिंपल सा मंडा लगाते हैं, जो भी स्क्वामस था ना उसको भी कॉलमनार बना दे. So what it does is, whatever was the squamous epithelium, now they started to transform into the columnar epithelium. When they transform from one form of epithelium to another, this is what we call it as metaplasia. So you will see that this is now undergoing this compensatory change to avoid damage. Okay. So you see the new squamous epithelial cells have now transformed into columnar, but what happens is they also bring something along with them, right? They bring a baggage. Now what are these baggages? These are the goblet cells. Now goblet cells produce mucin, but there's something spectacular about this. Now let's try to understand this. You will notice in order to get safe, you now see the squamous epithelium is now getting converted into this columnar epithelium, and this conversion is what we call it as metaplasia. Now this metaplasia is where the body is trying to save itself, right? What is happening in this metaplasia? You see the squamous cells which are present here are now getting converted into the columnar epithelial cells, but along with these columnar epithelial cells, they also have these goblet cells. Now basically the goblet cells, they produce mucin. When you look at goblet cells, what are their function? The goblet cells produce mucin and they are found in the intestinal mucosa. So they are native of intestinal mucosa, right? So you are now seeing in the esophagus, the squamous epithelial cells is now getting converted into columnar epithelium, but they also have the goblet cells. Now this conversion is called as metaplasia. Anywhere in the body metaplasia can occur. No, how do you know we are talking specifically about the Barrett's esophagus? So this metaplasia that has occurred is a special form because you have the goblet cells which produces mucin and they are native of the intestinal mucosa. So this is what we call it as the intestinal. This is what we call it as the intestinal type of metaplasia. This is what we call it as the intestinal type of metaplasia. This is what we call it as the intestinal type of metaplasia, right? So this is the whole phenomena of your Barrett's esophagus. In Barrett's esophagus, this compensation is occurring, right? Now, what is going to happen? If you talk about the clinical presentation of Barrett, they don't have anything specific. The clinical presentation of the Barrett's will have are signs and symptoms of GERD for prolonged period of time. For a prolonged period of time, that means if a patient is suffering from GERD for a long duration, right, and obviously on and off treatment, these are highly suspicious for Barrett's esophagus, right? So what you do is, any patient who comes to you with a long-standing GERD, the protocol says, right, the protocol says do an upper GI endoscopy. Now, when you do an upper GI endoscopy, UGIE stands for upper GI endoscopy. You have to perform something called as an upper GI endoscopy, right? So when you do an upper GI endoscopy, what is the finding that you're going to see? Now, you'll notice that if you see, this is the esophagus. I'm just giving you the esophageal component. You see, this is the squamous epithelial cells, which are usually light pink in color, and this is the columnar epithelial cells, which are bright pink or red in color. Now, we have learned before also, this squamo-columnar junction of the esophagus is what we call it as Z-line. Now, as you all know that in a Barrett's esophagus, this squamous epithelium is now getting converted into columnar epithelium. So you will see what will happen to the Z line. This Z line is going to shift up. You will notice that this Z line, which is supposed to be at this level, is now going to shift up. You see, this is where the Z line is now newly formed. So this is the new formed Z line, that is the squamo-columnar junction. So obviously at this area there are goblet cells also, but that cannot be seen on upper GI endoscopy, no. But just for the sake of understanding, there is a metaplasia that is occurred. So this was the old Z line that you had, and this is the new Z line. So you see the Z line is moved upwards because it is now transformed into columnar. Now, as an endoscopist, how do you know this? You will notice that this newly transformed area will appear to me as red velvety mucosa. This will appear to me as a red velvety mucosa. Okay. Now, when we say a red velvety mucosa, it's a characteristic presentation on an upper GI endoscopy as you see it during your scopy examination. Okay. Now, once you get this red and velvety mucosa, I now suspect the patient is having Barrett's esophagus. Okay. Now, on the basis of this upper GI endoscopy, so once you've done the upper GI endoscopy, we will measure this transition, this part that is getting transited, no, this red velvety mucosa that occurred, we are going to measure its length. Based upon this, I can divide them into three classical components. One is what we call it as the classic Barrett's. One is what we call it as classic Barrett's. Another one is what we call it as the short segment Barrett's. Another one is what we call it as the short segment Barrett's. And the new term that is introduced is what we call it as the cardiac metaplasia. This is what we call it as the cardiac metaplasia, right? So when I say it's a classic Barrett's, what do you mean by classic Barrett's is, now this red velvety mucosa length, right, that transform or metaplastic or this transition length that is present, if it is more than or equal to 3 centimeters, it is classic. If it is less than 3 centimeters, it is short segment. Now, if it is a cardiac metaplasia, it is an intestinal metaplasia. It is an intestinal metaplasia at the gastroesophageal junction without any macro changes. Without any macro. Now, when I say without any macro changes, that means there is no visible changes like red velvety mucosa, but when you take the biopsy, you will get this intestinal type of metaplasia. You will see there is intestinal metaplasia is present. Now, whenever you have a patient with Barrett's esophagus, now where you have this red velvety mucosa, the common sense dictates, because we need to understand that Barrett's esophagus, whatever might be the component, I will simply address this as a note point. Now, the minute you see the Barrett's esophagus, I'm a little bit worried. Why am I worried? I know that Barrett's esophagus, your Barrett's esophagus increases the risk for the adenocarcinoma of esophagus. It increases the risk for adenocarcinoma of the esophagus, right? Now, as it increases the risk for adenocarcinoma of the esophagus, I'm aware that this can happen, I need to be careful. So, whenever you're suspecting Barrett's, now the point is, if you're suspecting Barrett's esophagus, if you're suspecting Barrett's esophagus, the common sense dictates that the minute you have a presentation like this, take the patient for upper GI endoscopy, but along with that also perform biopsy. You do an upper GI endoscopy as well as biopsy. Now on the biopsy, I can have three findings. One, or rather than four. One, I can have normal. Second, I can have metaplasia, which tells you it is Barrett's. Third, I can have dysplasia, which is I'm worried about. Fourth, I can have malignancy, which is the worst possible outcome that your patient can have, right? So when you do a biopsy in a Barrett's esophagus, either वो normal होगा या थोड़ा मेटाप्लेसिया देखने को मिलेगा और the next phase dysplasia देखने को मिलेगा या फिर वो already malignant हो चुका है, ठीक है? If it is normal, because the patient had presented to us GRD, so I will simply say treat GRD. देखो Barrett's esophagus is not a disease, it's a presentation of an untreated GRD. तो आप Barrett's treat ही नहीं कर सकते जब तक GRD treat नहीं कर सकते. सेम लॉजिक आपके मेटाप्लेसिया वाले पेशेंट में भी है. यहाँ पे भी एडवाइस मेरा सिंपल होगा कि आप पेशेंट को बोलोगे कि बेटा हम आपका GRD ट्रीट करेंगे एंड दैट इज द होल ऑब्जेक्टिव दैट वी आर गोइंग टू लुक एट, राइट? So here also we are treating GRD, here also we are just addressing or a medical management, the medical management of GRD. So how will I understand dysplasia? बेटा your pathologist will tell you, no, आपके पैथो वाले बताएंगे कि भैया मेटाप्लेसिया के डिस्प्लेसिया वो उनका डोमेन है, करने दो उनको माइक्रोस्कोप में खोज खाज बताएंगे, जो होगा देख के बता देंगे मेटाप्लेसिया डिस्प्लेसिया. एज अ सर्जन मेरा काम क्या है? काटो, निकालो, फेंको, खत्म करो कहानी यार, ठीक है? अच्छा, ऑन द अदर हैंड अगर डिस्प्लेसिया है, ठीक है, if the dysplasia is present, now this is where I would like to go ahead with active intervention. Now इसमें I would do something called as an EMR. ये EMR क्या होता है? ये EMR ये आपका इलू इलू नहीं है, ठीक है? ये आपके जानू जानू वाला नहीं है, ठीक है? ये EMR है. तो EMR is nothing but endoscopic mucosal resection. EMR is your endoscopic mucosal resection, right? Now, how does this work is, let's say this is the surface and let's say this is the mucosal surface that is present here, right? And let's say this is the area where there is dysplasia is present, right? So how do you do an endoscopic mucosal resection is, I will take the endoscope, I will go under the mucosal surface, I will go under this area and I will normally inject a normal saline. Now, as I inject the normal saline, what is going to happen? You will see the normal saline is going to go in this area. Now, as the normal saline goes in this area is going to bulge. ठीक है? तो क्योंकि आपने fluid डाला हुआ है, it is now going to bulge. ठीक है? It is now going to bulge because of the fluid which is present here. Now, as it bulges, you will see it is going to push the mucosal surface up, or dysplasia is inside this mucosal surface. Okay? You have elevated this surface. All that I will do now, because I've elevated, I will now find a plane and I will resect this area. So this area will be resected out endoscopically. So you injected the fluid, created the space, आपका mucosal surface उठेगा, उसको फिर chop कर दो. And this is what we call it as endoscopic mucosal resection, which is done for dysplasia in Barrett's esophagus. Hi Mansoor, good evening. Right? But इसके साथ साथ आप क्या करोगे? EMR तो कर लिया. EMR के साथ साथ you will also treat Gastro Esophageal Reflux Disease. तो GRD भी treat करोगे, and this is a non-negotiable component that you have. ठीक है? Obviously, if it is going to be malignancy, the worst possible outcome, Then we'll discuss it. How do we treat it? We'll treat it as stage wise. So here we will go ahead and do a stage wise management, which we'll discuss in detail in our cancer component as well, right? So this is how you're going to address your Barrett's esophagus. Barrett's esophagus को हल्के में नहीं लेना है. This is a disease which can transform into malignancy. You cannot be easy on that. ठीक है. I'll just show you a couple of images of the endoscope so that you will be a little bit better on that to understand. Just give me a second. So far, any questions, any doubts, quick feedback? Quick feedback. Quick feedback. कोई सवाल, कोई शक? If you're good, let's close up the session. I'll just show you a couple of images. Just add these onto our slides as well. I'll just add a couple of images here. Let's see if you get these. That's your image number 1. This is your image number 2. And this will be your. Right. Now, when you look at this, this is the image number 1. This is the number 2. This is your image number 3. Now, when you have a patient with the first image, you can see this. This is the nice pink one. So when you talk about this pink part of the esophagus, this is your normal esophagus, and this is what we call it as the red velvety, right? And this red velvety mucosa signifies the patient is having Barrett's esophagus. The same is here. This is the normal esophagus. Now you can see there is these erosions which are present, and these erosions are now transforming into a red velvety mucosa. Right? This is quite evident when you look across here. Now, when you see here, this is again the same transition that is happening. This is a chromogramin image that you have, right? Right. So again, if you can see these areas, these are the normal squamous areas. You see this transiting form. These are nothing but your columnar component. Okay. So all these endoscopic image indicates that you are dealing with Barrett's esophagus. You're dealing with your Barrett's esophagus, right? So max to max, when they ask you these questions, this is how the component will be. Okay. If they want to make your life difficult, I don't think they should ask you in general about it, but then they can also ask you feline esophagus. I'll show you the image for feline esophagus also. So when you do a contrast imaging for the feline esophagus, just give me a second. Okay, got it. So in the feline esophagus, as we have told you before also, you will have the same components. I'll just add the images here for feline. So this is how your feline esophagus would look like. When you look at the feline esophagus, the classical description of the feline esophagus is your stacked mucosal ring. These are stacked mucosal. You can see it here also, right? So that is how they look on a feline esophagus. Now, as we have told that the feline esophagus can be seen in GERD. It can also be seen in eosinophilic esophagitis. See, another thing that you can see in your GERD is something called a Schatzki's ring, which are the lower mucosal webs which are present, can present as dysphagia. We'll discuss it as we go further in GERD. But this is the image series that you need to know. Love your notes and your diagrams. You have made surgery very, very easy. Thank you, Telugu Anna. So I think you'll understand Telugu. Thank you so much. I really like it when people appreciate all the hard work that we're putting in across. See, this series is like, it is like my baby, right? I've nurtured it since the beginning. I have the whole component of keeping the series to complete the entire Billion Love. It is more like your पहला पहला प्यार, ठीक है? ये वो प्यार है जो मतलब तसल्ली से पूरी की जाए. हर वो एफर्ट डालोगे, like no, you have a very fondness towards your first love, ठीक है? And this series is my first love. I am going to nurture the series in the same way. I am so glad it is the 49th episode of the BLS, not the 5th. Tomorrow it's going to be 50th. We'll make it 100 and we will complete the entire Bailey and Love. Unlike your पहला पहला प्यार जो हमेशा अधूरा रह जाता है, ठीक है? तो पहला प्यार अधूरा रह गया है तो अब वापस पहला प्यार करें ताकि इसको पूरा कर लें, ठीक है? So don't worry about it. We will run through the entire BLS series to complete the entire Bailey and Love. It's a promise, no matter what, howsoever, we will complete every single topic that is there in the Bailey. हम छोड़ेंगे नहीं, ठीक है? So if you have any questions, any queries, you know where to find us, you know where to reach out, you know where to ask us the question. Go find it. This is the surgery guide. Any questions, any queries, any difficult component, कुछ भी हो, just find me. It is both Instagram as well as Telegram. It is Dr. Sandeep Seram Reddy. The Reddy with an I, do not goof up. Go find this. You will find this ID on the Instagram as well as Telegram. Any questions, any queries, reach out to down here and we'll answer it. And we know tomorrow is our 50th episode. Please do join us. We will celebrate it together. It will mean a lot if you guys come across and interact with me tomorrow. We'll make the series even more bigger, better, and even more educating. Thank you so much for all the support and love. Until then, tomorrow, signing off. Goodbye. Take care. Have fun.